Welcome everyone to the second day of our 16th meeting of the Presidential Advisory Council on Combating Antibiotic Resistant Bacteria public meeting. I'll kick it off to Dr. Lonnie King, our co-chair.
Jemana, thank you very much. And good morning, everyone. I'm Lonnie King. I serve as vice chair of the PACCARB, and I'm honored to serve alongside the chair, Dr. Marty Blazer. I hope you had an opportunity to view the session yesterday. We thank our presenters. We had a really good dialogue and insight, and I think today we'll bring the same. So just a very short background into today's meeting. It was October of 2020 when the Assistant Secretary for Health tasked the Advisory Council to explore topics of variability in access, prescribing, and use of antibiotics, and that was yesterday's focus. And furthermore, to explore the use of interprofessional education and practice on antimicrobial resistance, in particular, looking at potential impact on infection prevention, control, and stewardship. Those are components, of course, of our national plan. As we did yesterday, we will drill down, explore, analyze data, learn from the experiences of experts across the One Health continuum. The task further requested that we pay close attention to education and professional curricula and identify opportunities for improvement. In addition to identify educational drivers and enablers impacting antimicrobial resistance and healthcare for both human and veterinary medicine, and potentially look at the correlation with education in universities and the professional settings such as continuing education. So this meeting is part of the process to end up delivering a final plan maybe in August or September of this year. So these public meetings become really important input as we are devising the final plan, which we will share in a public meeting later in the year. So let me turn it back to Dr. Jemana Musmar, our designated federal officer, who will briefly discuss the Council's rules and engagement, implement the roll call, and then she will introduce a special guest who is a patient to share his story. Jemana.
Thank you, Dr. King. And again, a sincere welcome to everyone for joining us again for day 2 of our virtual public meeting. After yesterday's enlightening conversations around antibiotic access and use, as mentioned by Dr. King, we hope this day continues much in the same way. Before we begin, a reminder to everyone that this meeting is being recorded via video conference and is also being streamed live at hhs.gov. Second, live verbal comment by pre-registered members of the general public will be provided this afternoon. Third, the Advisory Council is governed by the Federal Advisory Committee Act, or FACA, and as such, has rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups to obtain advice or recommendations where one or more members of the group are not federal employees. The majority of the work of this Advisory Council, including information gathering, drafting of reports, and development of recommendations, is performed by designated working groups who in turn report to the full Council for deliberation and final vote, as mentioned by Dr. King, which we aim to be in June of this year. Regarding the conflict of interest rules, all 15 voting members of the Council are considered special government employees, or SGEs, and are subject to conflict of interest laws and regulations. The 12 regular government employee members, or RGEs, representing different agencies and departments on the Council have also been vetted for any conflicts of interest. They have all received and reviewed information regarding the standards of ethical conduct for employees of the executive branch, and have previously provided information about their personal, professional, and financial interests. On the other hand, the representative members from various organizations are non-voting members of the Advisory Council and are not subject to the same FACA rules as the SGE or RGE members. I will now go through a roll call for all of our Council members. Please let us know if you are present by stating here, and for alternate representative members, please identify yourself and provide the name of the principal that you are representing today. We'll start off with our chairs, Dr. Blazer.
Here.
Dr. King.
Here.
Dr. Apley.
Here.
Stephanie Black.
Here.
Helen Boucher.
Here.
Sarah Cosgrove.
Here.
Paula Fedorka-Cray.
Here.
Christine Ginocchio.
Here.
Locke Carricker.
Here.
Kent Kester.
Here.
Elaine Larson.
Here.
Ramanan Lakshmanarian. Armando Nahum,
Here.
Paul Plummer,
Here.
David White.
Here.
All right, and that rounds up our SGEs. Thank you all for being with us today. Our non-voting members are next, the representatives of the American Association of Extension Veterinarians. Carla Houston.
Here.
AVMA, Joni Sheftel.
Here.
Bio, Greg Frank.
Present.
Thank you. DirectMed USA, Munir.
Grab it off my phone.
Here.
HICPAC is representative, Lisa Maragakis. PEDS, the Pediatric Infectious Diseases Society, Jason Newland.
Here.
Society of Infectious Disease Pharmacists, Elizabeth Dodds Ashley.
Here.
And lastly, Welcome Trust, Tim Jenks.
Here.
Thank you. Now on to our regular government employees and the agency, starting with USDA. ARS, Jeff Silverstein.
Yes, here.
Thank you. APHIS, Sarah Tomlinson.
Chelsea Shively here on behalf of Sarah Tomlinson.
Thank you, Chelsea. FSIS, Emilio Esteban. I know that he'll be joining us later on today. On behalf of DOD, Paige Waterman.
Here.
Thank you. And on to HHS, AHRQ, Jim Cleveland.
Here. Good morning, Jemana.
Good morning. CDC, Rima Khabaz.
Michael Craig on behalf of Rima Kabaz.
Thank you, Michael. CMS, Sherry Ling. Marge Cannon will be joining us on behalf of CMS later. Dennis Dixon.
Here.
Thank you. OGA, Larry Kerr.
Lynn Filthy for Larry Kerr.
Thank you, Lynn. Asper Barta, Chris Houchins. Anyone from Barta?
Hi, this is Anita Duran from BARDA.
Thank you. FDA, Bill Flynn.
Here.
Thank you. And then EPA, Jay Garland.
Here.
Thank you. Can I ask folks to please make sure that your lines are muted? Thank you so much. Lastly, thank you all again for joining. Just a few housekeeping tips, as we usually do. I ask all council members who wish to ask a question or have a comment to please send a private message today to Dr. Mark Kazmierczak, who is part of the council. If you see this background behind us, that means we're part of the support staff for the council, so you can send us a chat message with any questions. But Dr. Kazmierczak will be moderating today's Q&A sessions. Once you've been called on, remember to unmute yourself, and once you finish your question, mute yourself again. I now have the pleasure of introducing Michael McVeigh. Usually in all of our sessions, we start off with a patient story to remind everyone of the face of what we do and why we do it. And today we are honored to have Mr. McVeigh with us. He's an educator, an actor, a father, and a dog owner, and he embraces his self-defined role of small-town eccentric. And he's a native of Indiana, and he holds degrees in education and theater from Ball State University and the University of Cincinnati. And I'll now open it for Mr. McVeigh to share with us his tragic story, but with a great ending. Mr. McVeigh, go ahead.
Good morning, everyone. Jomana, you just shot my first full minute of presentation.
Keep going. We'll give it back. No worries.
I am here to present a human face for drug-resistant bacterial infections. Either that, or I'm comic relief, or it's your last chance to get rid of your morning's coffee. At any rate, any sequence or conjunction of coincidences can become a perfect storm, a disaster, or it can become a miracle. Medical science professionals and governments try endlessly and thanklessly, I might add, to increase the miracles and decrease the disasters. Disaster or miracle. My story is a composite of both disasters and miracles. First of all, the coincidences. I'm a retired 27-year veteran of university teaching. I only visit my doctor once or twice a year for checkups. I am not a hypochondriac. In 1997, my stomach was resectioned, and I have lived with dogs since the age of 3. And lastly, and most significantly, I bought a puppy without consulting my wife. It was not my brightest moment. The dog's name is Mabel. You can see her there at the bottom, all ears and a peanut-sized head. Less than a week after Mabel arrived, I was hospitalized. I was originally diagnosed at a weekend clinic with stomach flu. I was told just give it 48 hours, drink lots of water, and get plenty of rest. 24 hours after that, I was hospitalized with failing kidneys. There's a disaster. And then the miracle begins. The coincidences? First, after a week of hospital food, my sister-in-law, living in Seattle, 2,400 miles away, said, "Are you sure it's not that puppy? I've been reading about antibiotic-resistant bacterial infections on a CDC website." My sister-in-law is sometimes annoying, always relentless, and usually she's right. She was right this time. Upon hearing of this CDC website from my wife, my infectious disease doctor called the CDC. My illness was caused by a multi-drug resistant Campylobacter infection. The CDC suggested treatment was an intravenous antibiotic not commonly available. In fact, production was so limited that only small amounts were shipped to each hospital. The nursing staff each day would tell me where that day's dose had been borrowed from: Good Sam, Children, and other area hospitals. The CDC even genome sequenced my infection as well as Mabel's. They were identical. So after 30 days in the hospital, 2 trips to the ICU for internal bleeding, and a major surgery once again to resection my stomach, I was released from the hospital. My luck was indeed miraculous. My doctors and nurses were all exceptional. The CDC was easily available and very helpful. I was one of 63 people hospitalized nationally and one of 113 people diagnosed from a 17-state outbreak, all of which were related to infected pet store puppies. We still have Mabel. She's the white dog with a normal-sized head now. She finally grew into the ears. My wife calls her our $53,000 dog, or Typhoid Mabel. And consequently, I will never win another marital argument, because every argument effectively ends with, "Do you remember that little white dog?" It's truly a miracle that I'm still alive. And it's also truly a miracle that my loving wife has not chosen to resection my brain with a heavy, blunt instrument. I thank you very much for your kind attention. That's it.
Thank you, Mr. McVeigh. Dr. King, on to you.
Okay. Well, a special thanks to Mr. McVeigh for, I think, sharing this moving story and his miracle, for sure, and this personal experience. As Jemana previously stated, it's a part of each of our public PACCARB meetings that we are committed to having a patient share their compelling story that so authentically, eloquently serve as a reminder why this council was created in the first place and why each of our members is so passionate about our work together. So thanks again, Mr. McVeigh. And as a veterinarian, I'm glad that the dog, even though it's $53,000, is still an enjoyable pet. So let's go ahead and transition then into the meeting. I'd like to introduce our 2 chairs of this Interprofessional Education Working Group to lead our discussions for the rest of the day. Before doing so, I want to acknowledge the competent and hard work of some key staff members, Dr. Mark Kazmierczak, Haley Krim, who really did much of the heavy lifting to prepare this meeting today. So the two chairs are Dr. Elaine Larson of Columbia University and Dr. Paul Plummer of Iowa State University, who are serving as co-chairs for the working group. I thank them for their many efforts putting together the agenda and now turn the program over to their very capable leadership. Thanks.
All right. We appreciate that, Dr. King. And on behalf of Elaine and myself, we would like to echo Dr. King's appreciation for PACCARB staff. Mark and Haley and Jemana have played a huge role in preparing our agenda for today, and honestly, all of our efforts over the last couple of months. And I'd also like to express our appreciation for the working group members and the RGEs and others that have represented different ideas on the working group as we have arrived at today's agenda. So sincere appreciation for that. Mark, you can go to the next slide. So our working group came about as a result of a task statement that's available on the PACCARB website from the HHS Secretary. The mission of the working group is to investigate how interprofessional education and practice can be used to improve antimicrobial stewardship and infection prevention curricula, and to provide recommendations on how to incorporate IPE to strengthen training in national and state board certification and accreditation, as well as continuing education of health science professionals. We have several goals that include describing the status of IPE for antimicrobial stewardship and infection prevention, exploring curricula for all aspects of healthcare, including the One Health domains, and identifying opportunities for improvement in the relationship between antibiotic stewardship and IPE, and thus provide recommendations as to how the U.S. educational institutions, federal agencies, training programs, and specialty boards can strengthen their educational curriculum, board certification, and continuing education of One Health professionals. Next slide, Mark. So our task letter was received in October of 2020. We immediately started to work. Since that time, we've had 4 working group meetings. You can see those listed here. The first one focused on introduction to IPE with some speakers that actually we're going to have speak again today. Second one talked about IPE frameworks. In the third one, we looked at exemplars. And in the fourth one, we looked at lessons learned and started to work on a report outline. We anticipate our report out being in summer of 2021, bringing that back to the full PACCARB committee for review and voting at our next meeting. Next slide, Mark. So just to give an overview of where we believe that's heading, to frame up today, our current draft outline looks at gap analysis and recommendations, starting with a shared vision of interprofessional education in a One Health framework, using lessons learned from other existing programs and thinking about how we utilize One Health to frame up this larger concept of IPE. The second part moves past theory towards adoption and how we move this into professional schools, continuing education, and federal government, and finally focuses on defining and monitoring outcomes. And with that background on the draft outline, I'm going to turn it over to Dr. Larson for a few comments on today's schedule and introducing the first panel.
Thank you. So, Mark, let's have the next slide, please. Great. So this is an overview of our our 3 panels for today, which will help inform our report. But I just wanted to mention there have been a number of studies that have confirmed that uncoordinated care and lack of team collaboration, at least in acute care and intensive care, is significantly associated with untoward patient outcomes, including increased medical errors, patient adverse events, prolonged lengths of stay, and even higher risk of mortality. And a recent article in the American Journal of Infection Control proposed a collaborative framework to integrate antibiotic stewardship and infection prevention and control programs using a team science or interprofessional approach. This framework proposed 5 essential elements for team science: mutual trust, effective conflict management, accountability, common understanding, and open communication. So today we're going to hear from 3 panels and that will touch on some aspects of these 5 elements. What I'd like to do now is introduce the first panel, and our first speaker the first panel is called Interprofessional Education and One Health. And our first panel speaker is going to introduce and frame IPE. And I'm happy to welcome Patricia Cupps, who is a Health and Medicine Division in the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine. Patricia?
Great, thanks so much. If I could have the first slide, please. Great. So as you've heard, I'm Patricia Cupps. I direct the Global Forum on Innovation in Health Professional Education at the National Academies. And the views I'll be sharing with you today come primarily from the work of the forum and identified in these 4 reports that you can see in front of you. Next slide, please. So this is the forum. It's made up of 17 different health professions. So everything we do is really interprofessional. The forum provides a neutral platform where industry, government, academia, research can all come together to discuss the evidence. And basically, this is how interprofessional education works. It's really 2 or more health professions, well, we think health, but it would be 2 or more professions that work together toward a common goal. Next slide, please. So what I want to point out here is that if you go to the literature, you probably see a number of different terms used to describe interprofessional. You'll see multidisciplinary, interdisciplinary, interprofessional. Basically, there is no agreed upon definition for each of these. Some have tried, but they have failed. So really what you want to do is pay attention to the activities that are described or the activities that are observed. A lot of groups think that they're working interprofessionally, but instead it's really been described more as parallel play, where they work in the same setting, but if you watch them, they're really working side by side and not integrating and working together towards a common goal. And what I want to do is call your attention to the spectrum, the IPE spectrum at the bottom of the slide. On one end of the scale, you'll have really what I would not consider interprofessional. That would be students sitting in a lecture hall next to each other from students of other professions, but just sitting there quietly listening to the lecture. And then as you move down the scale or move up the scale, you will find that working together as professions towards a common goal. So this would be students maybe learning in the classroom, doing case-based exercises to try and figure out how to work together and using each expertise in order to reach a common goal. Then as you move up the scale, you have more active learning, and that would come from and with other professions in maybe a simulated environment. So it's not the real life setting, but it's a simulated setting where you can work together across professions to reach a common goal. And then you have the most robust IPE, which I would argue is IPE, and that's experiential learning that's bounded by class time, where you prepare for the experience, and then you actually go out into the community or wherever, and you experience the opportunity interprofessionally, and then you go back to the classroom where you reflect upon the experience that you just had. I also want to point out that there can be a similar analogy in the professional world, where, for example, if a group of health professionals are brought to a conference and they sit at a table, and the tables are intentionally interprofessional, and they sit quietly and listen to a lecture or listen to a presentation without interacting, that to me is really not interprofessional, especially if at the breaks they just go back and talk to people from their own profession. What would be more interprofessional is if there are tabletop exercises where the different professions have to work together to try and figure out a question or come to a conclusion, but somehow working together across professions to, again, reach a common goal. Next slide, please. So what I want to call out here is that IPE, and actually One Health as well, they're concepts. There's no real career trajectory. You can't graduate and become an IPEist or a One Healthist. They're really concepts. The other item from this slide that I want to call your attention to is the blue box. And if you look at the wedge in the blue box, that's interprofessional education. The ideal interprofessional education is really very little at the foundational level, because at that point, the learners don't really know who they are within their own profession. Where the greatest impact can be served is in the practice environment, where the different professions are working together, again, towards a common goal. But that's an opportunity where those in the foundational level of education can actually experience a well-functioning team working together interprofessionally, assuming you can actually find those well-functioning teams, which some would argue that they're difficult to find, but when they're out there, it's a great opportunity for learning. But again, what happens currently is that the wedge is actually flipped the other direction. So a lot of the interprofessional education takes place at the foundational level, and it becomes less and less as you get into the practice environment. Next slide, please. So what are the challenges facing IPE and arguably One Health? First is logistics. You're going to hear this from pretty much anyone that tries to do IPE, that it's hard to match up schedules, and there's different levels of training when you're trying to match the different students. There's also language differences. So I'll give you an example. There's a group that I work with. They're made up of 14 different health professions who took 2 years to come up with a definition of interprofessional professionalism. And that was because each one of the health professions spoke a different language. So they were saying the same thing, but they had different ways of saying it. It took them 2 years to be able to come up with a joint definition. And this group they're all in the health field. So you've also got cultural differences. There's those who train using a biomedical model. And then there's also those who train using biopsychosocial, spiritual. And again, this is in the health professions, and looking at the different cultures between human health, animal health, and the environment. I think that this could be an opportunity, but it could also be a challenge. And then third is the turf. Really, in interprofessional, sort of who gets the funding really has the power, and this is something that I think it'll kind of get into sort of getting over the obstacles, but having leadership training for everybody, I think, is important. That whenever called upon, if everyone's trained to be a leader, when it's your area of expertise, you need to stand ready to lead the group, and others need to stand ready to follow. So having that leadership training that's interprofessional and understood by everyone is critically important. Next slide, please. So getting over trying to overcome the challenges. One is with language, learning from and with other sectors and across the learning continuum, so that you start to understand the different ways that things are described across the different professions. Culture, IPE is really based on a culture of respectful engagement. There's no blaming, and this notion of flat hierarchy is important. There's also the turf issues, as I mentioned previously, that, if there can be IPE, if there's, or interprofessional work, if the funding is split equally across the One Health areas, that will flatten the hierarchy. And it's also important to be aware of sort of the unfunded mandates, where if one group gets funded and the others are asked to volunteer, I'm not sure that would necessarily go so well. And then the other way to overcome some of the challenges is to create champions, those who understand all three languages. They can actually truly understand the challenges that are faced by the health professions, that are faced by the animal health professionals, and those who work in the environment. Next slide, please. So when thinking about the different components for learning opportunity, I would suggest 4 areas of focus. One being looking at behavior, and that could be the behavior of the prescribers, it could be the behavior of the users, but that's an important component, as well as data collection and analysis, and understanding the science, the biology, the pharmacokinetics. That I would think would be an important component, And then the fourth piece really pulls all of those other aspects together in an opportunity for advocacy. And the advocacy could be at the individual level. It could be to the local government. It could be local area issues, national, international. It could be, again, at an individual level, or it could be at a policy level. And this can take place from the foundational through to the practice environment. It's just the depth in which they are explored. Next slide, please. So this is where I'm going to finish off here, is with an example that I think exemplifies everything I just described. It's out of the Minnesota Department of Health. It's the Minnesota One Health Antibiotic Stewardship Collaborative. It's made up of industry, government, research, academia, and they all come from the different sectors of human, animal, environmental health. And it's learning across the professions and across the different sectors. Next slide, please. So the collaborative goes on interprofessional field trips, and they've gone to the acute care hospital, long-term care facility. When they go to the places like the hospital and care facilities, the team is led by the human health experts. When they go to a field trip to the dairy farm, obviously that's led by the animal health experts. And then when they've actually gone to the river to collect water samples, the environmental experts lead that activity. They've also gone to the Minnesota State Fair to host a booth. And this is where the different sectors come together and they provide information from the different areas of One Health. And this, to me, is a perfect opportunity for bringing in the foundational learners, the learners in the foundational level of their education. And this is where they can see how the different sectors can work together. I think it's a great opportunity to introduce them, not just to interprofessional work, but also to the topic as well. And then they also have masters and PhDs who collect and analyze data to identify hotspots in the area. So they have field samples to collect antibiotic use, to recognize how much is in the environment. They have data to understand the correlation between action, and action being things like, activities to try and decrease the use of antibiotics and how that might affect the environment. And then advocacy for behavior change. And I would argue that they could go beyond just advocacy for behavior change. They could also work towards policy change using the evidence that they've collected. Next slide, please. And much of the pieces that I described to you today can be found in these reports. I believe that's it. Thank you very much. Dr. Larson, I believe you're muted.
Thank you. Thank you, Patricia Cupps. Our second speaker in this panel of four is speaking on core competencies in One Health education. Dr. Joanna Mazet is from the University of California, Davis. She's the founding executive director of the UC Davis One Health Initiative. Dr. Mazet.
Well, thanks for having me. And I'd also just like to follow up from Dr. Huff's presentation to say much of what I will talk about in the beginning, at least here, is the result of another National Academy's effort. So under the leadership actually of Dr. King, who's guiding us today, the Forum on Microbial Threats instigated and developed a One Health activity, which is now in a somewhat independent National Academy activity called the One Health Action Collaborative. And so some of the results of the first pieces on One Health education are definitely the views of the authors of the papers, but come from the work of the One Health Action Collaborative of the National Academies. Next slide, please. All right, so one of the things that we as an action collaborative wanted to work to address first are these complex health challenges and how we get the interprofessional, if you will, education stimulated to really be able to train the next generation of problem solvers for these very difficult problems that the world is facing. And so we really felt like we needed to start at that foundational place and look at the training in One Health and where it has been and where it is going. So we did do next slide, please. We did do a large survey looking at One Health education and use the definition that's maybe a little broader than I'm hearing you use today. So the current definition in the community, the One Health community, is really the definition that's been endorsed now by CDC, USDA, many different agencies and academic institutions like my own. And it pulls plants out. So we always kind of thought about plants in the environmental sector. And because actually agriculture and the systems around agriculture are quite different than what most people think about when they think about the environmental sector, I think it was really smart and forward thinking to pull the plants out for food safety and security. And when we think about One Health, we're really talking about two things. We're talking about the collaborative, interdisciplinary, respectful approach that we are applying to the second central tenet, and that is the intersection of health issues at this human, animal, environmental, and plant interface. Next slide. And so what we did first was to look at what was happening with One Health education in the U.S. And in a broad survey and direct reaching out to academic institutions all across the country, we were able to identify, and this is now a couple years ago, 45 One Health academic degree programs across the country that specifically were focusing and teaching the One Health approach. Now, they may have a specific focus that was the focus that was the strength of their university, and that's fine, actually recommended, and I'll talk about that. But I do want to show you that it does blend all the way from bachelor's, master's, and doctoral programs. I'm also proud to say that that the CDC and our own program at Davis were the oldest programs that we found, going back many, many decades, more than half a century actually. But the vast majority of these programs have started since 2012. Next slide. All right, and by looking at these programs, we were able to really evaluate what things were well represented amongst almost all of the programs, 75% or more, you can see in the well represented side. And that actually is interesting because epidemiology and environmental health and ecology were extremely well represented. What were poorly represented, if you look at the other end, the gray end of the spectrum, were plant health, antimicrobial resistance, and law. We did find truly one health program in a law school, but the vast majority of the programs that we found were focused in schools of health sciences, including veterinary medicine, public health, and then to a lesser extent, schools of dentistry, nursing, pharmacy, medicine. Next slide. And through this process, we were able to deeply and richly assess these programs and how they felt that they were delivering their education. And we were able to come up with 3 competency domains under which all of our core competencies that we recommended could fall. Now, there's been a lot done in One Health education and interprofessional education that may or may not be similar to One Health, but in the One Health area, there were lots of recommendations for core competency-based education and the domains under which people should develop. But this is the first time that we actually came out and recommended core competencies that be included in every One Health program. And again, you can't read them here. You can go to the paper if you like. Health knowledge was important. That wasn't a core competency before. I think it was assumed that everybody would have health knowledge, but many of those new programs weren't teaching health knowledge. They were teaching a lot of the other approach pieces. And then really understanding and a rich process by which you could explore and learn if you are moving from situation to situation, the global and local issues in humans, animals, plants, and the environment, and then professional characteristics. And all of the programs emphasize that communication and interdisciplinary respect were absolutely central tenets that needed to be strengthened, and strengthened all the way through education, as Dr. Cupps said. Next slide, please. All right, and then our next step was actually to get out and to survey, and this is now going global. So that first paper was really looking at education at the U.S. base, the national level. We then took a survey and went international with it to both evaluate the learners, so the graduates of One Health programs and the students currently enrolled in One Health programs, and then what they were doing with it afterwards and what they were missing in their education, and also how did that match up with the employers and what they were looking for. So what you can see that I wanted to highlight is that the students, the graduates, the workers, and employers all ranked the two top most important characteristics equally, and that was interpersonal communication and communication with scientific and non-scientific audiences, so getting to the risk communication piece, and then the ability to build, work in, and manage transdisciplinary teams. Then after we drop down on their priorities, it starts to move a bit, but we still see some clustering where sometimes the employers might rank things a little differently than the graduates, or might want things a little different than what the graduates think they want out of their programs, but it was still fairly clustered and consistent. Next slide. All right, I'd like to just take this now to, I was asked to talk about how we are looking at One Health education at UC Davis and beyond. And at UC Davis specifically, we have actually developed an undergraduate global disease biology core competency-based undergraduate program that is teaching global disease biology, but all of the soft skills and the interdisciplinary respect in One Health. And those students are going on now. It was the most quickly subscribed and the highest subscribed undergraduate major ever developed at the University of California, Davis. And it is now producing students that are going into all of the health disciplines, as well as engineering, environmental health, and we're really proud to see where those students are going. We also run, and I'm a co-director of the One Health Workforce Next Generation Project, where we're working with 24 institutions in Africa and 152 faculties in Southeast Asia to train the next generation of One Health leaders. Next slide, please. And through that process, we are developing, actually at the request of our two secretariats. One's called AfriHoon and one's called SIAHoon. They're the Africa and Southeast Asia One Health academic networks, and both of them are developing workforce academies where they are providing teaching material to their universities, working on curricular development, communities of practice, and again, echoing Dr. Cupps' point that we really need to go all the way into experiential and peer-to-peer learning. Now, one thing that I think is interesting here is that the AfriHoon group is moving towards accreditation for One Health. And one of the most important things for that accreditation is that it's not really a one-size-fits-all, because we do need the universities and their graduates to have an area of emphasis where they bring a disciplinary area of strength to the table, but also are trained in the One Health approach. Next slide, please. And then finally, just looking at that from an antimicrobial resistance perspective, we are seeing and developing really wonderful One Health approaches to identifying resistance genes and linking them through a One Health approach to people, animals, environment, and hopefully we'll get the plants in there too. This first study that I'll show you coming out of Nepal from my colleagues, you can see we were testing households in the environment, the people in the households, the wildlife around the households, the water, as well as the domestic animals. And if you give me one more click, my final slide is just to show you that then we can map the resistance genes throughout this community. This is in Nepal. And really identify the larger genes are those that are linked to more of the hosts in that community. And you can see that many of those genes are linked to species and sources that we wouldn't normally think of. So if I could just leave you with a parting thought, I believe that we are nicely represented here today, and a lot of what I've heard so far from the human community, more heavily, frankly, than the veterinary community. And we talk about the environmental community, but we're not always bringing them in as much as we'd like. So I think that's an area of growth. Thanks.
Well, thank you, Mazette, for a very exciting presentation and exciting work. So I hope you'll see in the next presenter, our next panelist, that we're trying to model interdisciplinary, interprofessional work. We're going to hear from a dentist. The title is Interprofessional Learning, Experience and Practice, Dr. Catherine Demko from the School of Dental Medicine at Case Western University.
Good morning, everyone, and thank you. I'm very pleased to be here, and I appreciate the opportunity to present our program. First off, I want to say I wish I was a dentist, but I am not. I'm actually an epidemiologist by training, and the dental community has been very welcoming to me at Case Western Reserve. So in 2016, a small group of faculty received funding from the Josiah Macy Jr. Foundation to develop a interprofessional education model for the clinical environment. And that led to the development of ILEAP, the Interprofessional Learning, Experience and Practice Model. Next slide, please. We recognized the importance of developing a more comprehensive model around team skills, and a model that would more closely link learning and assessment, a model that would more closely connect foundational training of team skills with the clinical application of team skills, and a model that would foster team development in that practice-based experience in the clinical setting. So on the right is a graphic representation of the ILEAP model. Its implementation is grounded in three major components. The first is a rigorous preparation of all ILEAP participants through a formal readiness curriculum. Second, as we move into the clinical experience, students have a formal team skills-based curriculum at the site, which guides learning and allows the students to interactively be working together and with patients and contributing value to that patient care process at the site. And the third component, which both links and supports the first two, is a robust mixed methods assessment and evaluation plan that's implemented throughout the curriculum. And we believe that this curriculum provides some concrete guidance and some substantive content to interprofessional education. And it really does help to clarify some of these complex relationships among all of these subcomponents, resulting in a more cohesive curriculum for our students. Next slide, please. So here's just a high-level overview of the assessment and evaluation plan that we used in ILEAP. It included mixed methods so that we collected data in both qualitative and quantitative formats. And we used data sources that were both self-report and direct observation. And I'm going to spend a little time on Dottie and direct observation in just a minute. We also used a multi-level approach to examine the responses among all levels of participants. And this allowed us to collect actually quite a bit of process and output measures, some short-term intermediate outcomes, basically student knowledge, attitude, and their Dottie skills, their team skills, and several higher-level impact measures. For example, the value added in patient care at the site as determined by the site, and the site's capability and capacity and sustainability for accepting future teams at that site. Patient health outcomes. I wish I had better news here. This is clearly the most challenging piece. We have made some progress, but it often depends on the capability of the site to abstract data that's related to the patients that the students have seen. So we continue that work. I want to mention briefly that the idea of self-report and direct observation. Many IPE programs use self-report. That's a very important piece. But we didn't want to only have self-report, which is why we made a strong commitment to balance that with a direct observation approach. You have the next slide, please. So here's Dottie. Dottie is the direct observation of team interactions. It's the instrument that we created for use in the ILEAP program. It's comprised of 15 team-focused skills organized in 4 domains. And these are all based on IPEC competencies and some of the reports that have been presented by the first 2 speakers. Some of these behaviors and many of the definitions that we created definitions that would characterize low performance and high performance of these skills. Many of them are quite granular, and it's because we were dealing with students who are novice team members. Also, if you've been in IPE, there's nothing quite like the first day when students come together. They come in the room, they drop their backpacks, they sit down, they roll their eyes, they open their laptops, and they say to each other, I know how to do this, I've been on teams. So this is one of the first challenges we face, is helping students understand that teamwork in healthcare has different dimensions to it. Finally, one of the strengths of Dottie is that it can be administered multiple times, certainly by multiple observers, and this helps you capture change in the performance of these behaviors. Also, it contributes to the reliability and the validity of the direct observation. Next slide, please. So I know that you couldn't read that screenshot, so I just want you to be able to see the 4 domains and the 15 team skills that we focus on. Task communication, interpersonal communication, I heard that mentioned previously. Roles and leadership, certainly models of shared leadership we try for the students to implement, and team process. And the 15 specific behaviors are listed under there, and the council members have all received a Dottie form to look at. May I have the next slide, please? So Dottie truly connects all of the different subcomponents of the ILEAP model, and it's progressive. We start with training of our faculty, our facilitators, our coaches, so that they, in fact, are all speaking that common language that we heard about. Dottie is used in the readiness curriculum to introduce the basics of team skills to the students, and then that's usually supplemented by simulation activities where the students have an opportunity to practice these team skills in a controlled and safe environment, and our simulations often include standardized patients. It moves then to on-site, where in the clinical environment, students work interactively and are guided by Dottie to practice their team skills and to then self-assess and write reflections on their team skills. In the gold circle, the coaches that are present with the teams on site can offer real-time, formative, and actionable feedback to help the teams improve their skills. And finally, Dottie is used in summative assessment to directly observe the teams and rate them. And while we have focused primarily on early learners, those are the students who are first year in their professional training program, Dottie and ILEAP as a whole are certainly amenable to being used with more advanced learners, potentially with professional practicing teams. I heard CE mentioned as a possible way to introduce team skills and the One Health approach. And we believe this is quite possible with the ILEAP approach. Next slide, please. Actually, may I have the next slide? I've covered most of those things. What I really want to spend a minute on is looking at the flow of learning in a typical ILEAP team day so that you could perhaps get some idea of how these different clinical topics, antibiotic resistance or stewardship, infection control practices, might be embedded in a team skills IPE curriculum. So on the screen here is a clinical example. This is health maintenance and preventive services screening. This is a typical topic for our teams when they are placed at the federally qualified health clinics. So these 6 boxes represent the 6 steps that occur in a typical ILEAP day. On the left, the first box, which is the pre-brief, and the 5th and 6th boxes on the right, the huddle and the debrief, are pretty core components. They're implemented quite similarly regardless of the setting. There are checklists to guide the students through the activities for these boxes. Box 2, 3, and 4 represent the more amenable pieces of ILEAP. So right here, we're talking about health maintenance screening. So a typical activity would be for the student team to review an electronic health record. Meantime, the provider is seeing the patient. And then the students, typically in pairs, not the entire team, but in pairs, will go in, talk with the patient, offer some health education and some health promotion. I could easily envision that the patient conversation might center around antibiotic use, freeing up some provider time and having the students communicate with the patient about that topic. Outside of that patient interaction, I could envision these clinical teams discussing antibiotic stewardship, prescribing, infection control practices as a common goal and a common clinical team. Now, in our teams, the students are from medicine, dentistry, nursing, physician assistant programs, and social work. So that's appropriate for the clinical environment. But I could further imagine this in a simulation setting in which now our teams are comprised of human health care students, animal health care students, environmental students, and plant students, which I hadn't thought of before, but I want to mention I've just learned that. And that team then would have that common goal, that one health approach of discussing antibiotic resistance, antibiotic stewardship, an opportunity to bring in any other evidence-based practice that students could be learning about while they're learning and practicing their team skills in a clinic environment, perhaps, or prior to that in a simulated environment. So I hope that gives you some idea, how we could envision melding these two and putting IPE as another tool in your educational toolbox to deal with antibiotic resistance. Next slide, please. This was clearly an interprofessional effort on our part, again, acknowledging the grant support from the Josiah Macy Foundation. And on that grant, Dr. Ellen Lubers was the principal investigator, and there's our interprofessional faculty. On the left are our clinical partners, and on the right are educational partners from each of the schools, as well as students from the clinician scientist program at the Cleveland Clinic. Last slide, please. This is our contact information. We welcome any feedback or questions. And probably in the next week to 10 days, we will be actually launching a website, which will have a lot more information about ILEAP and Dottie worksheets and ways to support you if this is an approach people are interested in. So thank you very much.
Thank you, Dr. Demko. Very exciting. And our last speaker in this panel is Dr. David Farmer, who's going to talk about, he's going to give us another exemplar of an interprofessional education program from the University of North Texas Health Center at Fort Worth. Dr. Farmer is the founding director of the Institutional Department of Interprofessional Education and Practice there. Dr. Farmer?
Thank you so much for having me today. If we could go ahead to the next slide, please. Just a quick brief on who we are, the University of North Texas Health Science Center. We were founded in 1970, and we consist of 6 programs: the Texas College of Osteopathic Medicine, a graduate school of biomedical sciences, our School of Public Health, our School of Health Professions that consist of our physician assistant program and physical therapy program, and our UNT System College of Pharmacy. And our newest program is a collaboration between Texas Christian University and HSC, and it's our new school, Allopathic School of Medicine. Next slide. So you've already gotten some introductions. I think Dr. Cupps did a great job on kind of talking about that gap that has existed. We know certainly there's been that gap in the integration of collective competence education in both the preclinical and clinical learning environments that exist. And probably the scariest part of that of all is that middle statement there, that once our students are actually out in the clinical learning environment, it's almost expected. It's been very passive, the teaching of these collective competencies for teamwork, either assuming that they already know how to function appropriately within an interprofessional team, or that somehow implicitly they're going to learn to be that team member. The scary part of that is often what they see out in those clinical sites that is often not representative of what we would like them to learn about teamwork. So we've had a very large effort to integrate the explicit instruction on teamwork competencies in both the preclinical and the clinical learning environments. Next slide, please. So our Department of Interprofessional Education was established in 2012 under the direction of our current institutional president, Mike Williams, who is a physician and also had been a CEO in a hospital, and really came to us recognizing the gap that existed and the need for interprofessional education initiatives. So really our department leads those initiatives, and the first thing we did was build off relationships that we had with neighboring institutions. So we created an IPE relationship with several institutions in our area: Texas Christian University, Texas Woman's University, Texas Wesleyan, and the University of Texas, Arlington. We now have a brand new relationship that's developing with the Tarrant County College District and their health professions. And what it allows us to do was to bring together 11 professions across those 5 institutions, so that our students have an opportunity to learn about, from, and with each other. Next slide, please. The way we've set it up is we have centralized interprofessional education, and those are really those initiatives that are led by the institutional IPE department. It's really those 5 institutions operating together to bring 11 health professions together. We create 4 workshops across year 1 and year 2 for our health profession students. Our philosophy has been, my background is in psychology, and so our philosophy has been, if we bring these students together very early in their programs and help them begin to get used to each other, to know each other, to appreciate and to value each other, that we can help foster that across their programs, then helping them enter those clinical sites with a better understanding and appreciation for each other. We have 40+ interprofessional faculty facilitators that help us with these workshops. And in these workshops, we cover the 4 IPEC core competencies. They're mandatory for all of our first and second year students. We just did one of these a couple of weeks ago. We had approximately 800 students across the 5 institutions, came together across 2 afternoons, divided into 4 sessions, so we could accommodate all those students. And these are all integrated into each program's curriculum. So we wanted to be sure that they're embedded in the curriculum so they'll continue to exist. But not only are we doing the centralized activities, but we also have decentralized interprofessional education that's occurring too. And this is more bubbling up from the programs themselves. The health professions program drive these. 2 or more of the health professions collaborate. They're championed by program faculty, and they're integrated into the course curriculum. I want to share one of those. I have several examples there, but one in particular I wanted to share is one. It's a program that's really run out of our geriatrics division, where medicine, pharmacy, physician assistants, physical therapy, nursing, dietetic, social work, speech language pathology, students participate together. They go out in small interprofessional teams of 4, and they visit with local seniors who have volunteered to be a part of the program. They have competency-based assignments. They brief before they go out. They meet with their senior volunteer. They perform these competency-based assignments with them. They come back and they debrief on that, and they're able to debrief on their team activity and how they function together as a team. We get feedback from the senior as well on those activities and how the students interacted with them. Next slide, please. We're also working with a clinical learning environment. Again, I talked about that concern early on as to what our students are seeing and experiencing in the clinical learning environment. One in particular I want to highlight is one that's occurring in our pediatric clinic. Back in 2012, when I first started doing IPE as director of IPE, one of our pediatricians, Dr. Habiba, approached me. She said, you know, in our pediatric clinic, we have a large population of patients who come who are obese or overweight, and we're making referrals to a local hospital in the hospital district to a dietitian there for them to follow up with. But our concern is that they're not following up. They're never seeing the dietitian. So she asked, do you think one of our partnering institutions that has a dietetic program would be interested in having their students, their upper level students, come into our clinic to help assess and to educate the parents while they're at the visit with their children? And so we approached our partner, Texas Christian University, and the dietetics clerkship director was excited about the program, immediately got her upper level students involved in this, and we created what we called the pediatric dietetics internship partnership with them. And so we had medical students and PA students who were working with dietetic students who would actually brief on the patients. They would go in and visit with the patient, do a nutritional assessment with the patient and their family, and then begin to create some SMART goals for them, some recommendations around nutrition. And then they would work with the attending pediatrician. And then they would follow up with the patient after that visit to see if the patient's family was following up on those SMART nutritional goals. We had the opportunity, those students then would debrief about their visit together, talking about their teamwork. And so our pediatricians were learning from the dietetics students. The dietetic students were learning with and from the PA and the medical students as well. Others we've had, our family medicine clinic has medicine, PA, and pharmacy collaborations where pharmacy is collaborating with our PA and medicine practitioners as well. And then certainly in our geriatrics clinic, we've had PT, medicine, social work, and mental health collaborations there. Another of our interesting collaborations that I get to be a part of is in our osteopathic medical school, where for our second year medical students, we actually team teach on Monday afternoons. Because of my psychology background, I team teach with a physician. We teach small groups of medical students who interview their patients, and then we interact with them to talk about their interviewing skills. But more than that, we get to talk about those larger issues, those disparities often that their patients are facing, those psychosocial issues that they're facing, and the opportunity for involvement of social work, involvement of pharmacy, involvement of mental health in those as well. It's fun to be able to be in that class and for the physician and I to get to play off each other and for the students to see our interactions with each other and our collaborations as well as a model. Next slide, please. The thing we discovered as well, and this Dr. Cupps talked about this, was the need to train faculty and preceptors as well. Several years ago, we started doing an IPE faculty development program. I've got a picture here of an escape room that they're working on together in that. And so we began to bring interprofessional faculty together, realizing that if we're going to train students, we need to train faculty and to integrate this into their classrooms, their courses as well. And it was widely accepted. Faculty have signed up and participated in our program. We were very excited in February of last year. We introduced a preceptor development program at a local community, our local hospital, and we were able to begin to train preceptors, but COVID hit. And now we've created a micro-credential for faculty and preceptors that we're going to be offering statewide as well as nationally. Last slide, or next slide, sorry. Due to COVID, we took everything online. We've been assessing. We're finding that our outcomes for both the in-person and the online have been very similar. And learner assessment, we didn't want to lose ground due to COVID. Next slide, I believe this is my last slide. We've tried some innovation. We're doing Team Steps training. It's a national team development program. We borrowed from the University of Washington, did Legos training where they come together and build towers, talk about their teamwork together. Couldn't do that because of COVID. We've moved now to using the virtual game Minecraft as a way of allowing the students to continue to work together online. Again, as we assess them, we're getting similar results in the in-person and the online training. Again, I believe the next one is my actual last slide. Next slide. Last thing is in Texas, we have an IPE consortium that's made up of 28 private and public academic institutional members across Texas. It's a learning community around IPE in which we're sharing our innovations and the work that we're doing in IPE. So thank you. I'll be happy to answer any questions at the end if there are questions.
Terrific. Thank you, all four of you. Patricia Cupps, Joanna Mazette, Catherine Demko, and David Farmer for a very exciting panel. And now I'll turn it over to Mark, who will manage our council questions.
Thank you very much, Elaine. Again, if anyone has any questions to ask the presenters, please send me a message. I'm going to open it up with our working group co-chairs, Dr. Larson, Dr. Plummer. Following that will be Dr. King and Dr. Craig. So Elaine, do you have any questions for our panelists?
I am very grateful for we have some echoing here. Very grateful for the examples, the exemplars that we got. Actually, for over a decade with funding from NIH, I co-taught a graduate course with a biostatistician called Building Interdisciplinary Research Models. It was designed to enhance team science among health professionals, primarily physicians and nurses, but also including dentists, bioethicists, nutritionists, public health practitioners. And it became very clear in the course that there were wide gaps in culture and values. As Patricia Cupps pointed out, it took us a year just to develop our definition of what everybody could agree on as interdisciplinary education. My question is that it's quite late in the game to start interprofessional education in graduate school, although it's better at that point than not at all, because our course participants, for the first time often, had a chance to listen to each other and gain some respect for their respective skills and expertise, and appreciate the differences in their values and language and culture. But I have a question for any of the speakers on when and how do you think we should be starting this kind of education, and what kind of changes in our educational system might this take? It's kind of a big question, but do what you can.
Well, I'm happy to start. I do think that we should start it as early as possible. And I think that the easiest place to start is with the respect piece. And we heard a lot about having champions. I think that's critical. I guess I don't necessarily agree that we all need to speak the same languages if we're respectful of other people's disciplinary languages and can also be humble enough to ask questions when we don't know if the words are being used in the same way that we think they're needed to be used. I do think that could be infused into every disciplinary track of education at all levels. But I believe we're finding that starting very early is incredibly helpful.
So I might add on to that, the notion that starting early is critically important, maybe even starting before the birth of the health professional, to think about the faculty, the preceptors, as well as the care providers, so that when the learners enter the environment, they're actually learning from well-functioning teams, so that those who are role models, the learners can see in action how interprofessional how it can work and the value. I will add that I was talking to a palliative care pharmacist the other day, and it was kind of interesting, her perspective. Palliative care is known for its highly interprofessional actions and nature, and she considers herself like part of the team, not just as a pharmacist. So she's 100% pharmacist, but she said that she's 10% social worker, 10% nurse, 10% doctor, because she feels in her area it's critically important to be able to speak the language so that there can be a warm handoff from one profession to the other, so that it's not just, oh, I don't know that answer, somebody else, but you also know the skill set of the others who are on the team, so that you can very quickly, you can ease the handoff from one health professional to the other, but also you know who it is that you want to reach out to cover that issue.
And then I would agree as early as possible, but a couple of thoughts in this. In educator training, I think this is something we need to be introducing, helping educators to think outside the silos of their training for other opportunities. And then even across graduate programs to those undergraduate programs, we had a program that was offered or was initiated between our PT program and early architectural students, where they worked together and they went around campus in wheelchairs or on crutches, and they had to look at the environment and test the environment and see the impact of the environment based on movement disabilities. And so I think we have to look for innovative, outside the box ways of thinking to take an approach different than we've taken in the past to how we're going to educate our students, looking at that we all are interconnected in ways that we perhaps never realized that we are.
Thank you. I'll just make one final comment to what Ms. Cupps said, or Dr. Cupps said, and that is sometimes I'm very disturbed. I'm a nurse, and I hear nurses in the hospital when a patient asks a question about an antibiotic, like what's the side effects or how long should I take it or whatever. And when their response is, ask your doctor. Well, that's fine, and that's important, but there are a lot of things that, we need to prepare each other and support each other to do. Thank you.
Dr. Plummer, you're next.
Yes, appreciate all the presentations. And Dr. Farmer kind of commented on how they've addressed this important issue of putting into practice or actually kind of immersion, practical type of activities, moving that to virtual. And so I was just interested from the other speakers, and obviously, Dr. Mazant, you're dealing with very geographically dispersed folks as much more so than just even a state, but how do you integrate virtual training, virtual simulations into your activities?
So this is Catherine Demko. I'm going to make a quick comment on that. What happened for us was we have a student-run health clinic, which also
well, we've been using. Are we okay?
Yeah, Dr. Demko, go ahead, and then we'll let Dr. Mazant add on.
Okay, thank you. We have a student-run health clinic that uses our iLEAP model as well. And when COVID hit, the site that we use, the federally qualified health clinic, was very supportive in finding ways for our students to continue to interact virtually and then to actually interact still with patients. So the students did come in, they were socially distanced when they came to the site, but then continued to work with patients on the particular topic of colon cancer testing, a FIT test, and talking to the patients online or on the phone. So we found ways to adapt. The students are very adept actually at having their virtual meetings and having some meaningful conversation. And the Dottie trainings that we've done have all been online. So there are definitely ways to continue that movement forward, as Dr. Farmer indicated.
I think our next question is from Dr. King.
Well, thanks very much. Yeah, those are great talks, very informative and very rich. So thank you all for that. So I had a question, maybe Dr. Cupps, we could start with you, but any of our our presenters can comment on that. So two of the core competencies in IPE are value and ethics, and then also roles and responsibilities, which I think much talk to mutual respect and how people's expertise add value to a team. So why that's an important learning and an important outcome in this pedagogy, what I would be interested in is, and our group talked about this, is about professional identity and professionalism. Rather than to wait and say, okay, when we work together, we'll reinforce this idea. Why isn't this an expectation of a successful physician or veterinarian or nurse or pharmacist? So it seems like, there's a disconnect there that could really help IPE and embed it in an expectation of professionalism and a professional identity. We haven't done this very well in veterinary medicine, but I know human medicine is starting to go. So any thoughts about that and how that could be reinforced and part of IPE?
So if I'm understanding the question correctly, you're asking about an interprofessional identity? Is that correct?
Well, it starts with a professional identity, but it could be an interprofessional identity as they move on.
Right, okay. So I think the way I might frame this, and others may have different perspectives, is to think in terms of leadership, co-leadership, and followership. And understanding that if your expertise, and that would be your professional identity, if your expertise is really needed to address a particular issue, you need to step up. And it may be a co-lead because it may be that you're not the only one that has a particular expertise in an area that needs to be addressed, but stepping up and leading the team, but also recognizing that there are times when you co-lead and there are other times when you are not necessarily the right person to lead that group. And I think that we run a risk if we just choose the same person to lead every team, regardless of the issue that's being addressed. And I think that requires a professional identity. It also requires recognizing the skill set of those others who are on your team and recognizing when it's time to elevate yourself and when it's time to step down. So that would be my comment.
One of the things I would propose that certainly as part of your professional identity, we need to be teaching that the characteristic of teamwork is part of that professional identity for all of us. I think part of the struggle for a long time is, and the continued struggle is, that we haven't agreed upon what are those core characteristics or behaviors that we're going to teach that are related to teamwork, that we're all going to agree that these are behaviors that we all ought to be exhibiting. In Texas, our IP consortium that I talked about, we've tried to come together. One thing that we've agreed upon is team steps, and we've worked at our goal is to implement team steps across all health professions training programs in Texas, and we're actually training up master trainers to bring that into each of the programs. But I think if we could come to some agreed upon what are the characteristics, what are the behaviors. Eduardo Salas and Tannenbaum have a book out in which they describe 7 drivers of effective teams, which would be a good core curriculum that we could teach as part of professionalism so that we're training all of our professions to come out with these capabilities or these characteristics that are part of that professional identity.
Thank you. And our last question will go to Dr. Paula Craig.
Thank you very much to all the speakers. Excellent talks and very, very informative. And Dr. Farmer, that was a good segue into my question. It seems that, there was quite a bit of blue on the map showing the numerous states and schools that likely have IP-type programs, other types of programs that'll inform everybody across the profession. And I'm wondering, has there been any movement at all to try to aggregate all of these programs? Davis has one, Texas has one, Minnesota has one. It's still somewhat silent. And I'll leave that to any speaker.
So there are collaborations. There are IP collaborations. I believe Tennessee has an IP collaboration. There are other states that are doing that as well, that are bringing institutions together to work together in IP. In Texas, Texas Tech University, their Health Science Center, Texas A&M Health Science Center, the University of Texas Health Science Center systems are all working together. And as I've said, now we've come together with 28 institutions, private and public, that are working together in this. So we do see across the nation these institutional collaborations that are being established for this very purpose, to share innovations, to work together, to share resources, to help the state to grow in interprofessional practice.
In Ohio, CASE has begun to reach out to, and we have worked with some of the other medical schools across the state in using the program and the training. I would also mention that there is the Nexus, which is the umbrella organization, if you will, nationally for interprofessional education. They are an outstanding resource, particularly for documents and instruments and articles. And that certainly is an organization that could provide, I think, even some additional leadership and support for encouraging institutions to work together and share their findings.
I was actually going to bring up the same organization. It's the National Center for Interprofessional Education and Practice. And every year they have, well, their main event is a conference where many interprofessional educators and administrators come together to share ideas and experiences. And they've got work groups, they've got work sessions, they've got a whole host of different activities to try and get the learning from and with peers. And then there was one activity that they received additional funding from the Macy Foundation, really focused in on nurse leadership and had them address social determinants of health and on an interprofessional manner, and brought those together, those leaders together. I think that there were 12 of them, and they shared their experiences as well. So it's not quite the micro examples that we've heard before, which I think are extremely valuable, working with different programs working together, but more on, as Catherine said, more of the sort of the umbrella organization of where learning takes place and shared learning takes place.
Thank you all. And with that, I think we will end our Q&A. I would like to apologize to Dr. Mazet for our technical difficulties. With respect to virtual engagement, she did want to relay the comment that virtual communities in practice can be especially important during the COVID response. And the One Health Workforce Academies bring together more than 100 institutions internationally. So a good example of collaboration and cooperation there. So thank you all again to all of our presenters. I'll turn it back over to our working group co-chairs to close out and begin the next session.
All right. Well, we appreciate all of those presentations. That first panel was, again, kind of focused on interprofessional education, One Health, and some exemplars. And now in panel 5, we're going to move over to talking about individual drivers of change. And so here we're really wanting to take the opportunity to learn from some of our speakers and understand the individual's role in maintaining interprofessional and One Health ideas beyond the classroom into professional experience. And how can these concepts that we learn educationally be sustained in the practice, and what mechanisms do we have to or that exist to potentially encourage them to promote these in practices, and how can those be leveraged? So with that in mind, we have 3 speakers in this session. Each of you have 10 minutes. We would ask that you pay attention to that 10-minute mark because this session is standing between us and a short lunch break. So we want to make sure that we stay on time. And so our first speaker is Dr. Maria Walmsley, Director of Interprofessional Practice and Education at the University of California, San Francisco. Look forward to your presentation, Dr. Wams.
Thank you so much for that kind introduction. It's really exciting to be here today. I have to say I have a little bit of One Health envy after hearing about some of the programs. I'm going to talk about sustaining IPE into practice and some strategies for that. Next slide. It's no surprise, I think, to anyone on this conference call that we face some really serious healthcare challenges, whether it be quality of care, patient safety, access to care. And certainly these have only really been highlighted in the past year with the COVID-19 pandemic. I think it's clear to all of us that no one health profession working in a silo is going to be able to address these issues, and that we really need the collaborative efforts of all healthcare professionals to address some of these serious problems. Next slide. As others have said, we really need to train our healthcare professionals to be collaborators. And we also need to train them to have systems design skills, leadership skills, and quality improvement skills. I think those are really imperatives. And the question becomes, how can we best train them? And other speakers have kind of talked about this in previous talks. Next slide. So many of our institutions have developed IPE curricula that typically focus on our early learners. We want to start early. We almost want to inoculate them with a team mindset from early on and give them some knowledge and skills that they can apply in clinical settings. What we've heard from our learners is that they're disappointed when they get to clinical environments, and the reality that they see is that in most of our clinical environments, we're still practicing in silos. There are some bright spots of collaborative care, but in general, we're still practicing in silos. So how do we sustain these interprofessional skills and attitudes as our learners progress from early learner to resident and then on into practice? And I think that is the dilemma we face as a field. Next slide. A lot of people have talked about this dilemma and the idea that we need to develop interprofessional education and collaborative practice in tandem, that developing one alone is really not going to solve our problems. And some people have coined the term interprofessional education and collaborative practice to kind of represent that. I think this is going to take a culture shift for us. It's going to take a culture shift in our clinical environments, and acknowledging that our practicing healthcare professionals have to be both learners and teachers in these settings. So they have to teach our learners, but they also have to be learners themselves and develop these skills in practice. What might that look like? What are some strategies that might help us accomplish this? Next slide. I think the first strategy is to continue to invest in new models of education and care. You heard this morning about some really innovative programs, and many of them were grant funded. So, to be able to continue to innovate, I think we need to think about continued funding. We were fortunate in San Francisco at our VA Medical Center to be one of the recipients of the Education and Patient Aligned Care Teams grants through the Department of Veterans Affairs. And these grants were really, had twofold goals. The first was to radically redesign health professions education in primary care settings and to improve care in those settings and switching to a more team-based model. There were 5 sites across the country, and they've subsequently expanded. And what we learned from those initiatives is that there were some really impressive outcomes in terms of learner competency, staff and trainee perceptions of collaborative care relationships, and then patient outcomes, such as improved diabetes control, more timely mental health referrals, increased team visits. So we need to continue to push to invest in these models of care, to disseminate what works and what doesn't work, and then to incentivize other systems to adopt some of the best practices that we've seen. Next slide. I think the second thing is that we have to acknowledge that although collaboration in our workplace settings isn't perfect, there is still much interprofessional learning to be had, even in our less than ideal teams. Most of the learning that occurs in workplaces presently around interprofessional care is really informal. It's experiential, and it may go unrecognized if we don't highlight it. And we need to make that implicit learning explicit to both our learners in the workplace and to healthcare professionals. How might we do that? Well, I think the first thing is really to explore with interprofessional teams whether or not we value learning from each other, and what are the structures that might enable us to do that, whether it be capitalizing on team huddles or on multidisciplinary rounds to really try to enhance those existing structures that we have that provide opportunities for learning, and then to make those opportunities explicit. We also need to introduce time for team reflection on team processes, and we need to include our learners in these conversations. So I think one of the speakers mentioned about the fact that we just put our learners into workplace settings and expect them to function as team members, and I think we need to really make the learning explicit. This really requires leadership on teams that value interprofessional learning in the context of the healthcare team, and also requires faculty who are skilled in capitalizing on interprofessional learning opportunities. So I think we have our work cut out for us, but I do think that there are some real opportunities out there. Next slide. I think one real opportunity for us is systems improvement work. And we need to engage both our learners and our teams in systems improvement and think about how we can do that and maximize interprofessional learning in that context. At the UCSF School of Medicine, all of our learners are embedded in clinical microsystems starting day one. And in those clinical microsystems, they work side by side with the coach and with staff in those settings to design and implement a systems improvement project. So they might work with a bedside nurse, a data manager, a nursing supervisor. And the goals of this experience are really twofold. The first is we want our students to learn systems improvement skills so they can take those as they move forward. And then the second is we feel like our learners can add value in those clinical settings. We were interested in learning, what do our learners get out of this in terms of interprofessional learning? And we interviewed learners after they participated in this experience, and we found that they gained knowledge of interprofessional roles and responsibilities, a greater appreciation for the knowledge and expertise that other healthcare professionals brought to the team, and then a recognition of the importance of interprofessional collaboration in order to optimize patient care. So these were early learners. We also do similar things with our residents. And I think involving teams in practice and systems improvement can really make a difference in terms of these interprofessional learning opportunities. Next slide. And lastly, I think we need to really think about how we prepare the workplace for our learners. What we know from the literature, and probably from the experiences of many in this room, is that we need joint leadership from both workplace and educational programs. We need to align the goals and priorities of our clinical and our educational missions, and influence the culture in our workplace settings so that they do provide learning around interprofessional collaboration. Co-location seems to be really key in order for us to foster this collaboration. I think when you have 2 or 3 healthcare professionals sharing the same space, collaboration is just much more likely to occur. This is certainly challenging in COVID-19 era. I'm from San Francisco, and space is a premium. So I think that this has been a barrier, although I'm excited to think about how to leverage technology and asynchronous communication now that we have those systems up and running, and whether or not there are more opportunities to bring our interprofessional colleagues in and collaborate around patient care. We need to define scope of practice and supervision guidelines for our interprofessional trainees and really focus on the value that they add to patient care. Great, next slide. I want to thank you for your time, and I look forward to hearing your questions. Thank you so much.
All right, thank you, Dr. Walmsley. Again, if you have questions, you can start submitting those by council members can by individual chat to Mark Kazmierczak. He will be compiling those for the queue. Our next talk is on enacting change through cooperative extension, and we'd like to welcome Dr. Roger Rennekamp, Health Director for the Cooperative Extension System, Association of Public and Land-Grant Universities.
Well, Paul, thank you so much. I appreciate the opportunity to spend time with you all today to talk a little bit about the cooperative extension system. And as Paul introduced, I am the Extension Health Director. This is the first time in my career that I have been institutionally agnostic. I've worked at several of the land-grant universities across the country, but today I work on behalf of all 111 to grow their capacity to work in the area of health and well-being. A lot of you know our organization for its history, but my position currently is funded by the Robert Wood Johnson Foundation, trying to catalyze a transformation in our organization, not necessarily to leave our agricultural roots, but to add health to the portfolio of work that we do across our cooperative extension system. So I thought I'd start off, next slide, please. I thought I'd start off a little bit because I think it's probably always good to talk a little bit about what is the cooperative extension system, because often we find that we may be a fairly well-kept secret across the country, but the cooperative extension system is the community outreach arm of the nation's land-grant university system. And it is funded cooperatively by federal, state, and local appropriations, as well as grants, gifts, contracts, and user fees. About 20% of the funding for cooperative extension comes from the National Institute of Food and Agriculture, and the network of these land-grant universities and their extension services were created by the Smith-Lever Act of 1914. This next point, I think, is where our true intersection can be with both interprofessional education as it relates to antimicrobial resistance. But across the country, we have 32,000 employees who are located in 3,100 county extension offices, serving every county in the nation. And that includes some of our HBCUs across the country and also about 35 tribal colleges across the nation as well. So where are these? Let's take a look at the next slide. And without talking too much about the difference in the 1862 and the 1890 and the 1994 land grants, those basically represent the years in which they became or received a land grant designation. But you can see that these are fairly well distributed across the United States. Every state has at least one land-grant university. In the South, there are several HBCUs that have land grant status. And then across the northern tier of the country, there are a number of tribal colleges that have that in fact have land grant status. Next slide, please. So, as we think about the cooperative extension system, and as I go back, of course, to the previous slide, and you can stay right where you are, but, I mentioned that I'd worked at 3 of those land grant institutions. And for example, at Oregon State University, they have offices in all 36 counties of Oregon. In Kentucky, there are offices of the University of Kentucky in all 120 counties. And then at Ohio State University, where I worked most recently, there are county extension offices in all 88 counties of the state of Ohio. These county-based extension professionals live and work in the communities they serve, and I think one of the pieces that is so powerful is that they develop trust with the residents in those communities where they work. And going back to the original creation of the cooperative extension system, that principle, was used in really transmission of science-based knowledge and mobilizing the knowledge that is embedded in those land-grant universities and really mobilizing them in a way that helps address national, state, and local issues. They're supported by a network of on-campus faculty with specialized knowledge in disciplines, and a lot of our folks at the county level are more generalists in terms of the work that they do. Lots of times, and probably still most prominently, the Extension Service is operated from a College of Agriculture or its variant, as you see in different universities. But more and more, we're seeing it administered in a little bit different ways, more frequently becoming university-wide in nature with a chancellor, vice president, or vice provost for outreach and engagement. And part of what we're really finding is so critical is building a science-literate society across the country, because no matter what issue we're dealing with, there needs to be a base level of science understanding to help the public change their behaviors to understand the purpose of what they do. Next slide, please. So a lot of these folks in the communities, our extension professionals in the communities, engage producers of our food. They also engage with consumers. And in a lot of cases, they engage with youth. A few moments ago, I talked a little bit about science literate society. And in my grocery store trip yesterday, I saw GMO-free bottled water. And then in previous trips to the grocery store, or actually this was in a buffet line, I saw gluten-free pork. And then the real kicker was the DNA-free vegetables, and that kind of thing that were offered to the public. So folks need to have a base level of understanding. So in fact, as we advertise and talk about things, people understand the significance of that particular work. Next slide, please. So what we see happening across cooperative extension, in addition to wherever they're structured in these land-grant universities, we're seeing cross-campus partnerships between our extension professionals and many, many different colleges or schools within those universities. More so, lots of partnerships with public health. Also today, we're seeing, and I'll talk about one of those examples later on, is with colleges of pharmacy. Also, colleges of agriculture, human sciences, veterinary medicine, which has been a big part of cooperative extension work for many, many years, is well represented here today, too. Social work, medicine, and nursing. We see those local county extension professionals working with local health departments. We see our extension faculty leading, facilitating, supporting, or being members of local coalitions, working on various health issues that can include antimicrobial resistance. And then currently we have a couple of projects going on right now, I think with the Centers for Disease Control and Prevention around immunization education. And then, as I mentioned, Robert Wood Johnson Foundation is making some significant investments in cooperative extension system to help it transform and build capacity to work in health areas. Next slide, please. And in particular, not just health-related work, but there is a growing focus on One Health in cooperative extension. And here's where I think, as we think about the role of cooperative extension and its relevance to the work that you're doing today necessarily, I look at it as being threefold as we talk about those 32,000 extension employees across the country. They come to our organization and we hire them either with bachelor's degrees, master's degrees, PhDs in a lot of cases. But I would venture to say that the understanding of the depth of One Health issues is probably rather minimal among our staff. So one of the ways that I think we have an opportunity to really engage and infuse an understanding of One Health principles is through something we call e-extension, which is part of the cooperative extension system, but it is really our virtual backbone that helps build capacity, collaboration among those individuals across the country. So I could certainly see us engaging in continuing education for our extension faculty and staff. And that's kind of one area that I see as an intersection. Number two is, in many cases, these county extension offices have been host sites for interprofessional education opportunities. They're used for practica, sites for students in the health sciences. We are currently working with the CDC's Public Health Associates program to help them create more rural host sites, for their public health associates. They're young professionals that are just moving out of academic training and into their field positions. So that's an area, I think, that particularly since 3,000 100 county extension offices across the country, we offer those as, in fact, host sites. And then the third one, I think, is that a lot of our folks that are working in the area of extension also have been involved in continuing education for physicians and public health professionals and such as well. So doing continuing education, through simulcast, asynchronous learning through those county extension offices is also an opportunity for us. And then next slide, please. And then also we're doing some exciting things across the country. And I mentioned the partnership, I think, with a program out of Ohio State University called Generation RX that is helping individuals learn how to use prescription medicine or prescription drugs more efficiently, effectively, and safely. Great program across the country. We have some opportunity to do work in. And I'll also mention our 4-H program in terms of youth health ambassadors. Many of those have intersections with animals, and we think that they're an opportunity to help spread the word about One Health. And I think that brings us pretty close to the end here. Might have another slide here, but I don't. If you are interested, you can contact me at rogerrennekamp@extension.org. So my purpose today is kind of to introduce you to cooperative extension and to think a little bit more about cooperative extension as perhaps one of those mechanisms or venues for interprofessional education or educating the public about One Health. So thank you so much, Paul.
Thank you, Dr. Rennekamp. And just one more reminder to council members, if you have one question, we're going to limit it to one per council member. Please go ahead and let Mark know so he can get those in the queue. Our final speaker for this panel is Sue Sheridan from the Society to Improve Diagnosis in Medicine, and she's going to present to us on Patients as Educators, a new partner in IPE.
Well, thank you, Mark, first of all, for the opportunity to share a perspective from the patient community. I should say patient and caregiver community. It's often a perspective that's missing in important discussions like this about medical education and IPE. So I thank you for your insight in inviting me. Today, I'm going to illustrate how very important IPE is, but more importantly, what I really want to do is share how patients as educators can enhance medical education and IPE. And when I say patient educators, I mean there are still very competent patients with lived experience that they can infuse their lived experience into IPE and into medical education. Next slide. So I'm going to start with a case study of patients as educators to show how patients as educators helped create a safer healthcare system. So this is my son, Cal. You can see on the left. This is maybe 13, 14 hours after birth, after a normal pregnancy and normal delivery. And here is Cal on the right-hand side, who is now 25, who is speech impaired, he's hearing impaired, and motor impaired. He requires that I use this photo of him now because he thinks he looks like a badass, and so I agreed to do that. But due to a cascading series of failures, communication failures, teamwork failures, coordination care failures, patient engagement failures, and overall systems and policy failures, Cal suffered brain damage from simple newborn jaundice that was not tested or treated in a timely manner. He has a condition called kernicterus, which is brain damage from newborn jaundice. That is something that was eradicated in the United States in the 1970s, but came back in the 1990s because of a variety of reasons. So when Cal was born, like I said, there was a cascading series of failures, but Cal was first noted to be jaundice when he was 14 hours old. This is a big red flag in newborns. But a series of nurses who were observing Cal noted that he was jaundiced, but never made the pediatrician aware, never called the pediatrician. Cal was discharged at 33 hours with no bilirubin test. Bilirubin test is the test that measures the level of jaundice in the bloodstream. Parent education for my husband, Pat, and me was not to worry, that jaundice was normal. So at home, Cal became, the second day, lethargic and hard to awaken. He wasn't breastfeeding as well. He was getting more yellow. I called the hospital. I called the pediatrician. I was dismissed as a overconcerned first-time mom. And so we eventually ended up taking Cal to the hospital. He was admitted on day 4. He was received by a resident who did the history and physical, who unfortunately erroneously documented the wrong blood type for Cal. He did not understand how the nurses made documentations in the birthing chart. So he misread the birthing chart and documented the wrong blood type. So a blood incompatibility was ruled out. A bilirubin test was finally done on Cal. For those of you who know bilirubin, his bili was 34.6, one of the highest ever recorded at the hospital. Again, there was no real action, no alarms going off, despite the fact that they redid the test. The lab kept asking to redo it because they thought it was too high. A neonatologist was consulted. However, there was no follow-up. On the second day, after Cal was admitted, he started to show signs of trembling, of posturing. He stopped breathing. There were separate consults. So a neurologist came in, an ENT expert came in, various residents came in, a whole line of nurses came in, the charge nurse came in, and more blood work was done. They did a lumbar puncture, they did an MRI. What was alarming to Pat and me was all these people were coming into Cal's room and doing their specific job. Yet there's no interaction or communication between the people. We'd say, hey, what, the neonatologist this or the neurologist that, and they said, no, that's not what we do. So everyone was doing their job, their individual jobs, but no one was doing their job together. So it was learned that Cal's MRI revealed brain damage from severe jaundice due to blood incompatibility. So today Cal has significant CP, cerebral palsy. He's a playwright. And a stand-up comedian, believe it or not, but he's speech and hearing impaired and motor impaired and has challenges that he should never have. So what if? So I have, as you can imagine, as a mom, I have a lot of what ifs. So what if I had been considered part of the care team? What if my reports of increased lethargy and yellow coloring and poor breastfeeding had been heard? What if people were really listening and I was taken seriously? What if I had been empowered with the right kind of information about the dangers of jaundice and that there was actually a test? What if the nurses, the pediatricians, the residents, the lab technicians, the radiologists, the neonatologists, the ENT, and the neurologists were all appropriately trained in standards on jaundice management and signs of kernicterus, but as well as on communication? What if they communicate with each other in a coordinated, seamless kind of way for safer care? If that had happened, I think Cal would have had a different outcome. Next slide, please. So this really made me ask myself, how do medical students and medical professions learn how to engage patients as part of the healthcare team and empower them with the right information? How do they learn to deliver coordinated care as a team around the goals and preferences of patients, and really understand and respect the challenges and burdens that illnesses and injury causes patients and their families? And really how to listen. How do they learn to really listen to and communicate with patients? How do they learn to raise issues and concerns constructively among the care team to keep patients safe? Now, I included this because in Cal's case, the nurses, all who noted early onset jaundice, were afraid, I'm going to say, or reluctant to challenge the pediatrician when they discharged Cal without a bilirubin test. So they were concerned about the hierarchy. So again, I asked myself, is the healthcare system really teaching medical schools and professionals to understand each other's roles and the importance of teamwork and coordinated care and communication to ensure high quality, safe care? The bigger question to me, though, is who would have some of the richest knowledge and experience to impart that wisdom on patient-centered care, on true patient-centered care? Next slide, please. So in the case of Kernicterus, the solution was patients as educators, and I'm going to say moms as educators. And we moms found each other via the intranet. We created a nonprofit. We knew exactly where the gaps were in care, and the necessary steps in improved education and policy making to protect newborns. So the other mothers and I like I said, we created a nonprofit. We invited partners and advisors that belong to the entire healthcare system to address the safety of newborns and education. So we together developed and delivered in collaboration with researchers and scientists and clinicians. We did grand rounds at healthcare systems, many of the systems where our children were born, to residents and clinicians. We offered input into curriculum development and delivery for national nursing organizations. We created and delivered with researchers and clinicians educational curricula and videos for CME. We participated in policy change and research with the CDC, the National Quality Forum, who called Kernicterus a never event, the Joint Commission, who issued sentinel event alerts and educated the healthcare system. The CDC issued MMWRs and helped educate the public health community, and they did that with patients as presenters. And we collaborated with medical schools, and I'm here in Idaho, and so I've worked with Idaho College of Medicine, and we've helped identify objectives and competencies for IPE, along with developing and delivering those classes. So the power of partnership with all these actors in healthcare really changed the learning and the standard of care. I would have to say, without the mom educators, no change in education or policy would have taken place. Next slide, please. So what I just shared with you is not really an isolated situation, and it really is happening around the world. So you can see that there's, from these here on this slide, they're partnering with patients in Canada and the US in IPE. The Institute for Patient Family-Centered Care has a big toolkit for those of you interested in how to go about engaging patients in IPE. The ACCME refers to patient engagement in medical education as a solid value-based strategy, and they have a criterion number 24 for accreditation with commendation that is on patient engagement. Next slide, please. So, people say, do we really need to engage patients? What does the literature say? Is there evidence? And I do want to share that what the literature is saying. Now, number one, the literature says that patients do wish to be involved. Probably most importantly, that teaching by patients has a lasting impact on technical skills, interpersonal skills, empathic understanding, developing an individual approach to the patient. And there are benefits for the patient educators and the instructors, and few disadvantages have been documented to date. Now, there's not a lot of evidence, but the evidence is beginning to come forth more and more, because this is a phenomena that's happening not only in the United States, but in Europe and around the world. Next slide, please. So what can we do now? Well, first of all, integrate patients as educators into the development and delivery of your IPE curricula. Identify leaders within your institution to really be the champion of patients as educators. Connect with local, national, and international patients and patients groups. They're everywhere. And prioritize the healthcare, such as patient safety, diagnostic error, or antibiotic resistant bacteria. Next slide. So in conclusion, this is really a question of will. There really are no real barriers to prevent patients as educators in getting integrated into medical education, or IPE. So my call to you is to be the courageous leaders that we need in medical education and embrace the wisdom and lived experience of the patient community as a valuable resource to bring the real world into your learners in IPE to ensure that we are safe from harm. You know, because I really believe that without the perspective and the input from the patient and caregiver community in IPE and in medical education, the medical education is incomplete. I have never heard a learner, as much as I've worked with them over the past 20 years, say that, boy, that pie chart or that bar graph is going to stick in my head forever. But patients as educators provide context that is tangible, it's palpable, it's real life, and it's enduring, that textbooks and lectures simply cannot deliver. I hope that in your final plan, you include patients as educators in your recommendations. Thank you.
Thank you very much. Very insightful, and appreciate the context and importance there in that. With this, I'll turn it back over to Mark. We're going to move into our council Q&A questions. Again, text Mark individually if council members for questions, and he'll get you in the queue. And just a reminder that we're limiting it to one question per council member. No two-part questions or that type of stuff to keep us on time. So, Mark, you can take it over.
Thank you, Dr. Plummer. We have 3 questions in the queue right now. So we'll start with Marty Blazer, then Libby Dodds-Ashley, and Lonnie King. We'll allow our working group co-chairs to close it out, but if other questions come in the meantime, those will be added to the queue as well. So, Dr. Blazer?
Yeah, thank you very much, Mark. I just want to congratulate and thank the speakers for their engaging discussions. They've really given us a lot to think about as we move forward. I want to address my question to Dr. Rennekamp about the Agricultural Extension Service, which, as you point out, is really a very robust nationwide organization. Lots of people out there who could be doing good. Also, a very long history of doing good. And I'm, as someone who's in medicine and not in agriculture per se, I just wonder, how much of a silo it's in. And I hate to use that metaphor, but now you mentioned about reaching out to professional schools, et cetera, in terms of the One Health concept. But I think the point I want to address and see if this is possible, in a country where half the people don't believe in evolution and so many people don't believe in climate change. As you say, there's a really serious issue of science underlying really everything that this panel is trying to do and so much else in modern society. And I just wonder if, in addition to the professional schools, the extension service, which are located at major universities all over the country, should reach out to the arts and sciences campuses to have discussions about evolution and ecology and really kind of fundamental principles that underlie everything that's going on in agriculture as well, and certainly underlie AMR. So I'd like to hear your views about that.
I think you make a very, very good point. And as we see across the country, there is a little bit of an evolution happening where, the administration of cooperative extension, is being lifted out of any one college and really, as I mentioned, really raised up to, a provost level or vice president level, where in fact cooperative extension really is an extension of all of the academic instances. I mean, in the state of Kentucky, where I'm based here in Lexington, and of course I'm not affiliated with the University of Kentucky anymore, but there are fine arts, extension agents, and that kind of thing in communities. So any of those pieces, as we really think about, any of the societal issues, I think there is a potential to really utilize these people in communities, our professionals, who generally are trusted, and in fact, can influence some people that maybe a regulatory agency may not be able to do it, where an educational institution might be better suited to help convince some of those. We also sometimes use that a cadre of volunteers or paraprofessionals, who are even more deeply embedded in communities, and that kind of thing. And then I mentioned briefly a little bit about young people too, in terms of them being ambassadors, because we know that most change in the world really has come about under the leadership of young people around the world. So I absolutely support your thoughts, about looking at all these areas and thinking about how we can build a science literate society. May well be starting with some of our young people as well.
Yeah, thank you very much. You've built up a century of trust. And now's the time to use it, certainly in the direction of AMR. Thank you.
Thank you.
Hello. I also have a question for Dr. Rennekamp. I really want to compliment you on the programs that you described. I'll share a brief vignette that recently, standing in the backyard with my husband, we had a disagreement over how to do some pruning. And I suggested we call the cooperative extension. I grew up in a rural community and my husband grew up in an urban community. And he looked at me like I had 5 heads and proceeded to not know about this resource. And so my question is, do you have data on the uptake and sort of brand recognition? Because I admit, as a pharmacist who does antibiotic stewardship, trying to do outreach for the community, I wasn't aware of this arm. And so what I'm wondering is if you have information on your uptake, particularly in urban areas, in areas for people who do not speak English as their first language, that would really help us better leverage some of your programs to these groups as we try to move forward the message of resistance.
Yes, absolutely. And thank you for the question. Every 10 years, there have been some assessments, done across the nation in terms of brand recognition of cooperative extension or county extension office or whatever it is. And what we've seen from 1980, where about 80% of the population at least had heard of cooperative extension, but as more people move towards urban and suburban areas, there's less people that have experienced it firsthand. So I think that is one of the challenges that we're facing is helping get a broad enough segment of the population aware of resourcing. So it
Dr. Rennekamp, I think we lost the last bit of that and you ended up on mute.
I think that's exactly right. Something strange happened, but exactly, yeah, the tail end anyway was I think we are in a lot of ways one of the best kept secrets across the country, in terms of linking land grants to the communities and helping improve even perception of the public about, the value of public higher education, which I think many of us are probably advocates for. Thanks for the question.
Thank you. Dr. King, you're next.
Okay, thanks. Well, thanks to the presenters and especially to Susan and Roger, who've given us really important dimensions that probably we don't think about in terms of IPE and education, but I think offer some very innovative strategies in terms of embedding AMR into our education. So thank you for that. And Roger and I were involved in Ohio in the opioid epidemic, where extension and public health became very important strategies in getting information to communities. So my question probably is best for Dr. Walmsley, but we've talked most of the morning and very importantly about optimizing patient care. So what I would like to know is how can we optimize population care? So AMR is a global pandemic, slow burning, but a global pandemic, and populations are at risk. And it seems to me like the strategy to improve patient care can also be a strategy to improve population care, reduce costs, and bring new innovations. So with that in mind, then you got to add a whole group of public health involved in IPE, certainly social sciences and some of the behavior issues. And I know social sciences and One Health now are really coming together. But certainly what we heard from Roger is agriculture and food safety and food systems. It seems to me like this is the right time maybe to take this to the next level. And that is not just patient care, but population care, and engage a lot larger community in this strategy.
Yeah, I really love that idea, and I would agree. We need to reach beyond the walls of our institutions and departments of public health or schools of public health, and really engage those folks in our effort. I think we need to teach all our learners to have systems thinking, and I think that's really the first step if we're talking about population health, whether it be in our local communities or more on the worldwide front. So I think expanding our reach and thinking about how can we, teach our learners to think beyond the walls of the hospital and think about partners in the community, I think is a really critical piece. And I know that some institutions have begun that conversation and are really trying to think about how they can partner with the departments of public health or community clinics to think about expanding the reach of the university and caring for the community at large.
We've got a number of more questions that have come in. So we're going to go now to David White, followed by Armando Nahum, Lot Carricker, and then closing it out will be Elaine Larson.
Great. Thanks, Mark. Yeah, thank you all for really good talks. As a member of a College of Agriculture, we work very closely with Extension and have done numerous times to help explain FDA, Center for Veterinary Medicine ideas and veterinary feed directive and antibiotic resistance. So we've been pretty effective in Tennessee doing that. Definitely an opportunity to extend that across the country. My question, I guess, is to Sue. Sue, thank you for sharing that personal story. I myself, a very similar situation where 19 years ago, I had twins that were premature by 2.5 months, born under 2 pounds, and at the NICU for 2.5 months while fellows and residents circled around us and no idea what was going on. My wife is a nurse, I'm a microbiologist. We started asking questions and they finally figured out we knew a little bit. So I agree completely with patients as educators. We need to do more of that. And there might be an opportunity to bring folks that are in the kind of professional areas too to help with that conversation with physicians and veterinarians as well. I just wanted your thoughts on that.
Please unmute.
Thank you. What I've seen over the past 20 years in terms of medical education, and not only about kernicterus and jaundice, but just medical education in general, how if we look at the whole ecosystem that's part of the care system and bring them all under one umbrella, to really improve care and safety, it makes a difference. And patients are very skilled and competent in becoming, partners in education. It's happening in Europe probably more than in the United States. There's trainings for it. We now have a toolkit in the United States for it. I think we can really encourage working with the accreditors of medical education and others that we can really ramp this up. Because like I said in my presentation, without the perspective of the patient in education, I really think our education is incomplete. And there's no better educator than, the patients with lived experience, quite honestly.
Thank you.
Great presentation from all the panelists, and so thank you very much. But my question is for my good friend Sue Sheridan. Hi, Sue. Sue, thank you again for sharing Cal's story. Always touches my heart. But I know you've done work across the globe. Canada, Europe, and when we talk about patients as educator in IPE, are we lagging behind in this country?
I would say yes. and this is just from my observation. I would say we are, or we have been, but I think I see in the past couple of years more interest and more integration of patients in IPE. Right now it's very ad hoc, and we really need to work very closely with the medical schools as a system to really integrate this concept. There are trainings to train patients on how to be educators, how to identify learning objectives, how to deliver presentations. I think this is a ripe time in our healthcare reform to do it systematically and very thoughtfully. So I'm eager and I'm excited about what's happening in the United States. The change is too slow, of course, and we can learn from Canada, we can learn from Europe. The momentum is happening though. And it'll take organizations and groups like you guys to go back to your institutions or put recommendations in your PACCARB recommendations to keep elevating this, to integrate it systematically.
Thank you.
You're welcome.
Thank you to all of the panelists. Really appreciate the information. My question is also for Sue Sheridan. I teach clinical veterinary students in the food animal arena, and so we put them in positions where they interact directly with farmers and producers as part of that, part of their clinical training. But what I find is that they often take the observations that they're able to glean and use them to reinforce their bias already on what's going on with the case and so forth. And so I'm really curious about, and we probably select for students who do that, who create some confidence in their decision-making, their preliminary diagnosis and so forth. So I'm curious, from your perspective, how do you preface that interaction to get them to take a little more objective approach to that interaction and those observations that they glean?
Oh gosh, I don't have the answer to that. It's a great question. I think that in terms of, being objective, it's kind of erasing, cleaning your slate and walking with a new, fresh set of eyes. I don't have the secret to that. I really don't know. Not a good answer, but that's a challenge.
Thank you.
Elaine, you're up next.
Sure. Thank you to everybody who's really made for a rich discussion. When Susan was talking about her experience from her perspective, it reminded me of something that happened to me about 20 years ago. I was giving a lecture in an interdisciplinary mandatory course for medical students and graduate nursing students, and it was on bioethics, and talking about sort of the interdisciplinary role of everybody in bioethics. And after the lecture, one of the med students came up to me and he said, "Dean Larson, that was a nice lecture, but you forgot something." And I said, "Yeah, what was that?" And he said, "Well, in order to be members of a team, you have to be equal." And I wasn't exactly sure what he meant, although I think I thought knew what he meant. And I was so shocked I didn't say anything, and he walked away. And I have to say I never followed up because it was a huge class and I didn't even know who it was. But I've thought about it since then, and I really appreciate the idea of the individual requirement to be a good team scientist. You've got to trust and you've got to have respect. And I agree with what Dr. Cupps said, and that is that the respect comes first of all for yourself and for your own expertise. So it seems to me that each of us in our respective disciplines needs to first feel that they're capable in their own field, and then to understand that it takes the whole team to work together. So with that, I think we are going to finish up and go for lunch. Jomana, do you want to give us instructions about when we're supposed to return?
Thank you, Elaine. I just want to confirm before we close out, are there any questions that are remaining? Anyone else want to ask our panel before we sign off briefly? Going once, going twice? All right, well, folks, thank you so much. Please be sure to only stop your video and only mute your computers, but please be sure to stop your videos during this break. Our break is scheduled from 12:30 to 1, but please return by 12:55 so we can ensure your connectivity. Members of the public, we'll be back at 1 o'clock promptly. Thank you so much for joining us as we continue panel 6. Have a good one.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.